the static areas where you have 3.5 millimeter at least of transmucosal zone is not easy. You have theoretically to make mechanical instrumentation to the surface which is more palatally displaced with respect to the soft tissue margin. I really have some doubt that the patient and the dental hygienist can clean this area so effectively without risking to traumatize the soft tissue margin and so create risk for gingival recession. In my opinion, if you have some minor inflammation, the best thing you should do is to unscrew the crown, place some gel of chlorhexidine in the transmucosal zone. Don't make any mechanical treatment unless outside of the oral mouth to smooth, to clean perfectly the subgingival portion of the implant-supported crown and screw it again. That's the best treatment you can do, and it takes 5 minutes. So screw retained crown, in my opinion, it's mandatory in the static areas. Not because only the problem of the cement that can be solved, but because the problem is that you need, in the case, to unscrew the crown. And you need to unscrew the crown not only in the case of inflammation or cures, but also to condition the tissue. Because this tissue that has been increased in thickness, in order to promote growing, you have to unscrew the crown, change the shape of the crown, change the shape of the contact point, and promote further growth. And to every single time you unscrew the crown, you should not disturb the connective tissue adhesion suprabony. And so, in my opinion, the best implant in the static areas is a transmucosal implant, tissue level, or, if you want, one abutment, one time concept, because one abutment, one time concept is exactly the same. You apply the abutment, time of the surgery, and then you unscrew the crown as many times as you want without disturbing the connective tissue adhesion forming into the abutment or into the suprabony component. But when we speak about suprabony component, you have to understand that it's also important the shape of the abutment and the shape of the suprabony, because if the suprabony component has a shape so that it gets too much close to the adjacent teeth, we squeeze the papilla. While if the shape of the abutment or the shape of the suprabony component is smaller than the implant diameter, we have a greater space for the papilla to grow in mesial distal thickness and buccal lingual. So the buccal lingual increase in the thickness of the papilla is due to the extension of the connective tissue graft to the base. So the increase in the buccal lingual dimension of the papilla is because we are able to increase the volume of the tissue interproximally by extending the connective tissue graft, also to the base of the papilla. But the mesial distal thickness, so the distance between the implant and the two adjacent teeth, is also influenced by the shape of the suprabony component. And the more space we leave, the more this papilla is thicker and the more they can grow in coronal direction, and the less is the risk to lose papilla height because the base is thicker. So if I have to give you, just from a soft tissue point of view, suggestion is that your implant should be screw retained. Cemented implant in the frontal area, it's a compromise, which sometimes we have to accept because of bad implant installation, bad positioning of the implant. That is the only reason why we can make cemented crown in the frontal area. The second one is that since you need to unscrew the crown many times during the conditioning phase, and eventually, if some inflammation occurs, you have to unscrew the crown. But the connection between the crown and the implant should be in the transmucosal zone, not at the level of the bone. So the biological width will not be disturbed by the unscrew of the crown. And this can be achieved with the transmucosal implant or one abutment, one time concept. And in both cases, I want that the suprabony component of this implant, abutment or suprabony component of the implant itself, leave greater space, suprabony, for the papilla to grow in the mesial distal and in the buccal lingual dimension. And the best way to increase the thickness of the connective tissue at the level of the papilla is to extend the connective tissue graft, which is mandatory for the buccal aspect to compensate for the lack of the suprabony component of the root, also to the base of the papilla. But this means that this graft should be covered by a coronally advanced flap.